This is my first clinical skills assessment. I'm currently in quarantine, so I'm going to have to use a mix of myself, a stuffed animal, and a pillow. So to begin, hi Mrs. Teddy Bear, my name is Kate and I'm going to be the nursing student looking after you today. Before I begin, I'm going to wash my hands. I have an alcohol-based hand sanitizer that's pre-portioned into a single amount. It should take about 15 seconds to dry, and I want to make sure it's fully dried. I'm using this rather than warm soap and water because my hands weren't visibly dirty, but if my hands were visibly dirty, I'd use warm soap and water. It's important to note that the 4 moments of hand hygiene are before contact with a patient in a patient's environment, before an aseptic procedure, before possible exposure to a bodily fluid, and after contact with a patient or a patient's environment. Next, I'm going to perform positive patient identification. So, Mrs. Teddy Bear, can you please tell me your full name and your date of birth? That matches my requisition. And can I also check your hospital ID band? Great, that also matches. Now I'm going to move on to vital signs. The first vital sign is temperature, and this is tested to get an idea of what a patient's core body temperature is, just to get an idea of the heat production versus heat loss. This is going to be an oral temperature. I want to make sure I get consent. Mrs. Teddy Bear, can I get your oral temperature? Great, this is going to go under your tongue. Perfect. So a temperature can range anywhere from 35.8 all the way to 37.3 degrees Celsius. Mrs. Teddy Bear's is 36.8, so hers is normal. Next, I'm going to perform heart rate. I'm going to do this on myself by taking my radial pulse and using this timepiece. So I'm going to count the number of beats for 30 seconds and then multiply by 2. So I counted 40, so I'm going to multiply that by 2 to get 80 beats per minute, which falls into the acceptable range, which can range anywhere from 50 to 95 beats per minute. Now, respiration rate is another vital sign, and this vital sign, it's important that your patient doesn't consciously know that you're taking it because it might increase their respiration rate. So you can, while you're taking the radial pulse, you can always watch their chest as well. So let's do this on myself for 30 seconds, count my number of respirations and multiply by 2, but it'll probably be a bit inaccurate. So I got 9, so I'm going to multiply that by 2 to get 18 respirations per minute, and the normal for me would fall anywhere between 10 and 20, so that's good. Then the last vital sign I'm going to take is blood pressure, and blood pressure is taken to see what the pressure of blood is against the vessel walls. I'm going to put an adult-sized cuff on myself, making sure that this arrow is right above my brachial artery. So what I'm going to do is I'm going to palpate and feel my brachial artery. Make sure my feet are uncrossed and that my arm is at heart level. Great. And then what I'm going to do is I'm going to increase the cuff and then release the cuff at 2 millimeters of mercury per second, and note the first sound and the last sound, which are the croak cough sounds. So I'm inflating it to around 160, then releasing. First sound is heard at 122. Last sound is 82. So my systolic is 122, and then my diastolic is 82. And a normal range for someone like me would be a systolic ideally less than 120 millimeters of mercury, and then a diastolic of less than 80 millimeters of mercury, but mine's okay. So I'm going to now move on to auscultation. So I have my lovely patient here, and what I'm going to do is start with auscultation of the heart. I'm going to palpate and feel for the second intercostal space. And this is where I'm going to be able to hear the aortic valve on the right hand side. I'll move to the left hand side, the same spot, second intercostal space, and this is where I'll be able to hear the pulmonic. And these are representative of the S2 sound, so the dub sound. Move down to the third intercostal space, which is Erb's point, which separates the base from the apex. And then move to the fifth intercostal space, which is the tricuspid valve. And then fifth intercostal space, mid-clavicular. That's the mitral valve, and tricuspid and mitral valve represent the S1 sound, so the lub sound. Now I'm going to move on to auscultation of the lungs. So I'm going to turn my patient around here and do the posterior side first. I'm going to feel for the first intercostal space, and I'm going to move in a stepwise pattern all the way until I get to the seventh intercostal space. And I'm going to ask the patient to breathe through their mouth, and I'll move my stethoscope after a round of inspiration and expiration. Great. And so since I was comparing both sides, I'd be able to hear if there are any differences between the sides, but everything sounded normal and I didn't hear any irregular sounds. Now I'll do the anterior chest. Again, same thing. Breathe in, breathe out. Breathe in, breathe out. Great, and both sides sounded normal and I didn't hear any irregular sounds. Now I'm going to move on to doing auscultation of the abdomen. It's important that I do this before palpation and percussion, because palpation and percussion can artificially increase bowel sounds. I'm going to imagine my patient's abdomen in 4 quadrants. In each quadrant I should hear anywhere from 5 to 30 bowel sounds per minute, but I'm also going to be listening to the bowel sounds to see, are they high pitched? Do I hear any rushing sounds? Because this might be indicative of hyperactive bowel sounds. Vice versa, if the patient didn't have that many bowel sounds, it might be indicative that they're hypoactive. If I didn't hear any bowel sounds in a particular quadrant, then I'd listen for a full 5 minutes before saying that that quadrant didn't have any bowel sounds. So start with the right lower quadrant by the ileocecal valve. Okay, that's good. Right upper quadrant. Good. Left upper quadrant. Good. And left lower quadrant. Good. And now I'll move on to palpation. So again, imagining the patient's abdomen as 4 quadrants. I'm going to start off with light palpation. This can let me know if there's any irregularities in the abdominal wall. So with light palpation, I'll start at the right lower quadrant and I'll palpate 1 to 2 centimeters. It's important before you palpate that you ask your patient if they have any abdominal pain. So do you have any abdominal pain? Nope. So if they did, then I'd probably just have to be careful, especially with deep palpation. So first, right lower quadrant, good. Right upper quadrant, left upper quadrant, left lower quadrant. Now I'm going to do deep palpation, and this is where I use 2 hands and I'll palpate 4 to 5 centimeters. This allows me to feel if there are any masses. So we'll start with the right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. Now I'm going to move on to percussion. I'm going to use my dominant hand, which is my left hand, to percuss, and I'm going to be tapping on my middle finger, again in the 4 different quadrants. We know that on the right side, this is where our liver is going to be at. So if I tap here, it's resonant, and then right upper quadrant, resonant. But if I move a little bit up just below the rib cage, then it's dull. So that's where I know where my my liver starts. And then if I continued up, I could continue until I stop hearing a dull sound, and that would tell me the top of my liver, and I'd be able to measure my liver span. So now moving to my left upper quadrant, it's resonant. But if it wasn't resonant, then this might tell me that the patient's spleen is enlarged. If it were dull, if it were a dull sound, then the patient's spleen could be enlarged. And now I'm going to move to the left lower quadrant, and it's resonant, and just above the pubic bone, and that's resonant. If it were dull, then that could tell me that the patient has a distended bladder that needs some attention. So this concludes my skills assessment. Thank you.